Okay, great. So I'm going to get started this evening with a brief literature review of some recent papers from the JOCI. So the three papers I was going to review tonight are from the August issue of JOCI. So the first paper I wanted to review is the validity of the primary immunodeficiency disease diagnoses in the United States Medicaid data by Hilary Hernandez-Trujillo et al. So this paper was, the goal of this paper was to assess whether the U.S. Medicaid program, which for those of you who don't know, is a subsidized health insurance program for low-income patients, whether this particular program is a good source for obtaining data about primary immunodeficiency patients. So they looked at Medicaid patients in 5 states, California, Florida, New York, Ohio, and Pennsylvania, who, I didn't realize this until I read this paper, account for about 40% of Medicaid enrollees, which is a large number of Medicaid patients. So the patients they looked at were patients that received an ICD-9 diagnosis for the following diseases: CVID, XA, hyper-IgM, or Westcott-Aldrich, and these diagnoses had to be given to each patient on two separate dates. So it's a total number of 223 patients that they looked at. The clinical data was abstracted, and the likelihood of having a correct diagnosis of a PID was verified by immunologists. So bottom line, what they found was there's a really low positive predictive value for these PID diagnoses, meaning that not very many patients were actually correctly diagnosed. The first thing they noted was that of the outpatient medical records available for the 233 patients, only 83 actually had records that are available for analysis. So it's a very low number of patients, very low number of available records, about a third of the patients. Most of the available the data that's available was mainly in patients who were mostly white patients. About half of them were female, and the median age of these patients were about 30 years. Only about 16 out of the 83 that were diagnosed as having a primary immunodeficiency disease were actually determined to have an actual possible PID, resulting in a positive predictive value of only 19.3%. Of this other 67 that were determined to not have a PID, the most common reason was that 73% actually had insufficient chart information to support the diagnosis. In terms of how they made these diagnoses, there was an algorithm in which they looked at clinical criteria for each PID, so each for CVID, XLA, hyper-IgM, or Westcott-Aldrich, in addition to whether there was actually written documentation in the chart as someone saying they had this PID. They also looked at seeing whether perhaps having a PID diagnosis as well as a CPT code for either a test or procedure, for example, getting IVIG, or, for example, being tested for having their immunoglobulin levels tested, whether having those two in the chart increase the positive predictive value for actually having a primary immunodeficiency disease. And again, the positive predictive value was very low, ranging from 11 to 41%. And actually only the patients that were diagnosed with XLA and those that received IVIG therapy had the highest positive predictive value for having a correctly diagnosed primary deficiency disease. And unfortunately, they were unable to find a diagnostic algorithm that could yield a reasonable positive predictive value over 80%. And so one of the limitations that they mentioned in their database was, in general, for the general population, primary deficiency diseases have a pretty low prevalence, so perhaps that may lead to some limitations in diagnosing primary deficiency diseases. 2, the ICD-9 coding that we're using currently until the end of September, or I guess for today and tomorrow, is not a very highly specific coding system, so perhaps we might be missing some patients with primary immunodeficiency diseases. 2, there may be diagnostic errors on the part of the diagnostician or the clinician. So it's possible that they may be inadvertently diagnosing people as having XLA using wrong criteria, or someone who's having CVID based on incorrect criteria. 2, there is definitely insufficient and poor chart data. As I mentioned before, only about 83 out of the 233 patients actually had any available outpatient medical records for analyses. And the last thing they mentioned was that, this is a claims-based data, So meaning that they looked at people who were claiming these diagnoses in order to get reimbursement. So it's very possible, for example, if someone needed to get, or coverage. So for example, someone needed to get coverage for immunoglobulin therapy, but they didn't really qualify 100% for having immunoglobulin therapy. Maybe they had not quite the correct clinical criteria. They may put in a different code just in order to get the immunoglobulin therapy covered. So by fudging that data, it may not be particularly accurate. So their summary, their conclusion was that the U.S. Medicaid data pretty much poorly identifies PID patients, and so perhaps we need to start looking at exploring maybe other types of databases to collect epidemiologic data on PID patients. For example, maybe actual EMR databases from practices like electronic medical records. And perhaps another possibility is to improve the accuracy of PID diagnoses in clinicians who take care of Medicaid patients. And then finally, it'd be interesting, this is a very timely article, since we are switching to ICD-10, perhaps could we get more specific diagnostic coding with the transition to the ICD-10 coding system. So that's the first paper. Let's see here. So the next paper I wanted to review was the Nijmegen-Breaker syndrome. So this is an interesting paper describing the clinical and immunologic features of these patients with MBS and looking at long-term outcome and treatment options with the retrospective analyses of the ACID database. So just to remind everybody, the NBN protein, which is Nibrin, is involved in double-strand DNA repair. And hypomorphic mutation in the NBN gene results in an abnormal Nibrin protein, so it's basically truncated, and therefore it leads to abnormal chromosomes and an increased sensitivity to ionizing radiation. These patients have typically a lot of dysmorphic faces, including a receding forehead, a long midface, a receding mandible, abnormal slanting palpebral fissures, as well as growth delay, and a very increased risk for malignancy. So this is a retrospective study of MBS patients who enrolled in the ACID registry. And the goal of the study that the authors had was to assess for any possible prognostic parameters that could help determine any long-term outcome and whether it could help determine which patients might qualify for a stem cell transplant or other sort of treatment options. They looked at 149 patients, and at the time of the study, only 61% were alive, with a median age of 14.3 years. All these patients met the ACID diagnostic criteria, and they all had the homozygous 5-base pair deletion in the exon 6 of the NBN gene. About 14 of these patients were post-stem cell transplant, and these transplants were done at a median age of 8.8 years, and of the 14 patients, 71% were alive at the time of the analysis. In terms of the clinical features and laboratory testing, most of these patients were of Central Eastern European origin, with 118 patients from Poland. In terms of infections, the upper respiratory tract infections were the most common. About 43% were considered as group 2, which what the authors did is they actually grouped patients by different groups in terms of the severity of the upper respiratory tract infections, with group 0 meaning the most mild, group 1 meaning having believe 0 to 3 infections, and then group 2 having several recurring infections are the most severe infections. So about 43% of these patients were considered group 2, meaning they had very severe or frequently recurring upper respiratory tract infections. Other infections that were noted were hepatitis, especially hepatitis B, hepatitis C, fungal infections, as well as EBV and CMV infections. In terms of their immunologic features, hypogammaglobulinemia, especially decreased IgG, was the most common, in addition to having to decrease IgA and IgM levels. The T and B cells, CD4, CD8, as well as the B cells, were particularly decreased, as well as decreased mitogen responses. But interestingly, in general, their NK cell numbers were normal. And in terms of their malignancies risk, about 40% of the patients were diagnosed with malignancy, and primarily lymphoid malignancies were the most common, and they were diagnosed at a very early median age of only 10.25 years. In terms of the outcomes, about three-quarters, a little less than three-quarters received IVIG. However, most did not receive any antimicrobial prophylaxis. And it looks like about 60% of the deaths, so a large number of the deaths were actually due to malignancy, then followed by infectious complications as the second most common cause for deaths. And in terms of the patients that were transplanted and the patients that did well versus the ones who did not do well, it appeared that having a history of malignancy seemed to affect the success of the stem cell transplant, as well as the risk for a relapse post-transplant. So this is a pretty good report for a multi-center experience with MBS patients up to date. So, unfortunately, one of the limitations that did include some limited or incomplete data on these MBS patients. However, this is a really good example of how like an ECID, a clinical registry, be very useful for sort of synthesizing information from multiple centers. And finally, these authors noted that malignancy, as to be expected, is the main risk factor that seems to be affecting survival and the decision to transplant these patients, as well as outcomes for hematopoietic stem cell transplant in the MBS patients. And then finally, the last paper I wanted to review was a novel targeted screening tool for hypogammaglobulinemia. It's a measurement of serum immunoglobulin levels using dried blood spots. So the goal of this paper was to determine whether dried blood spots may be used to screen for hypogammaglobulinemia. And the idea of this study was to determine whether using this could help improve early diagnosis of antibody disorders, as well as to provide an easy method for screening for hypogammaglobulinemia. And the rationale for this is that antibody disorders are probably the most common type of primary deficiency disease, and there's definitely a long latency period between when patients get diagnosed for hypogammaglobulinemia and begin their treatment for that. So what they did is they looked at 107 healthy subjects ranging in age from 11 months old to 57 years old. There's about 50-50 for males and females. I think a little bit more females than males. They used venous blood sampling as well as dried blood spots, and about 40 samples were obtained simultaneously. In terms of how the dried blood spots were processed, the cards were mailed out at room temperature, and when they were received, a punch sample from the dried blood spot was eluted with PBST. Was eluted for several hours, cooled down to about 2 to 8 degrees Celsius, incubated for 16 hours at a cool temperature, and then brought back up to room temperature. These samples were either processed immediately or then frozen up at -20 for up to a month before processing. And then what they did was they used these standard sandwich ELISA kits to measure IgG, IgA, and IgM. So in terms of comparing this to nephelometry, which is what we have been using to now to measure antibody levels, the correlation coefficient was fairly good. So it varied from 0.789 to 0.9, depending on the immunoglobulin class that we're studying. In terms of IgG, the lower limit of quantitation to the upper limit of quantitation ranged from 3.9 to 63.5. So basically, they normalized the range. Basically, they used an equation based on the nephelometry numbers and the IgG numbers to normalize the range, and they got a detection range from 370 to 6,832, and that is in comparison to the nephelometry range of 694 to 1618. So the whole point is that by using the dried blood spots, they're able to actually get a large range of quantification of detection limit, which actually in a way covers the nephelometry ranges, and in fact actually exceeds the nephelometry ranges. In terms of IgA, the normalized range was 63 up to 3,804 milligrams per deciliter. And again, this also covered the nephelometry range, which normally ranges from 81 to 463 milligrams per deciliter. And again, very similar for IgM, the range of 9 to 6,581 far exceeds the range for nephelometry, which is 48 to 271 milligrams per deciliter. And this is the normalized range. Of note, they basically really compared these ranges to like a normal adult reference ranges. So it was really applied to only patients who are 16 years and older. So it's interesting to note because they did use samples from very young children. However, they pretty much use these ranges in comparison to what we have considered normal adult reference ranges. And in terms of the precision and the accuracy, they note in the paper that they were able to get less than 25% coefficient variance for the IgG and less than 50% coefficients of variance for IgM and IgA, suggesting that the precision accuracy is fairly good. So they summarize in this paper that the benefits of the dried blood spots is that there's a definite decreased cost of processing, and the supplies are used to make these dried blood spots. And so these samples are definitely stable up to 14 days at room temperature, so they can be shipped by regular mail. So these dried blood spots can be done, in areas perhaps that are not necessarily accessible to labs or near labs, so they can be obtained and they can be held for several days and still be usable for processing. And they may be useful for screening up to large numbers of people. Some of the limitations of the study was that they only measured samples from healthy people, so it'd be interesting to see what kind of results they would get if they actually measured patients with actual primary deficiencies, for example, CVID patients. These levels were not adjusted for levels at a younger age, so they would have to adjust their the ranges for younger children. And also another thing to note is that most of these authors were funded by one of the immunoglobulin companies. So there's a little bit of a limitation there. So anyway, so that is a little bit brief literature review from the most recent JOCI issue.
Thank you, Joyce. That was really helpful. I especially liked the Nijmegen breakage syndrome paper. I think we don't think about that all the time. I try and remind myself to think about it any time there's microcephaly. It is such a devastating diagnosis. It's nice to see a big collection like that where you really can get a feel for the disease. We were going to start now with the first case by Thalita Diaz and Rhaianny Souza, but we don't see them on the phone lines anymore. Are you there and ready to start, or should we go with the other case? Thalita, are you there? I think I see a little. I don't see them, so I think we might go. Oh, wait. Someone is having trouble hearing. Let me just type a quick message to folks, but I think we will go it since I haven't heard from Thalita or Rhaianny. I think we'll start with Rob Sokolic, and we have two guest mentors. And I'm sorry, I should have started by saying this is sponsored by the Clinical Immunology Society, USIDNet, and the Latin American Society for Immune Deficiencies. And we have two guest mentors tonight: Alexandra Freeman from the NIH and Morna Dorsey from UCSF. And if we start with Rob Sokolic, it's going to be Morna Dorsey, who is our guest mentor. But before I let her talk, what we're going to do while we're queuing up Rob's case is I'm going to just warn you that I'm going to stop after Rob's first slide, which sort of lays out the case for you, and ask for some input. Hopefully all of you have figured out the chat function over on the left-hand side. There's a little box that you type into at the bottom. I'm just going to send a quick message now because it seems like a few people are having some technical problems. But while I'm doing that, we'll go ahead and pull up Rob's case and we'll get ready to get started. Okay, looks like we are ready. So our presenter is Rob Sokolic, who's now at the FDA, but I met Rob at the summer school some years ago and followed his career. He has a really interesting case for us tonight. You can see it's even got mystery in the title, so of course that means it's going to be a fascinoma for us. So Rob, why don't you go ahead and get started? And Morna, are you on the line? We might just have to work on Morna's phone. Jesse, can we work on Morna's phone? But Rob, go ahead and get started.
Okay. So the first thing I have to say, this presentation reflects my own personal views and is not the view of my new bosses at FDA. So this is our case. The patient was a 4-year-old boy with ADA SCID, and he presented typically in the first year of life with BCG lymphadenitis. Laboratory evaluation revealed lymphopenia. He was found to have elevated %DAXP, and a diagnosis of ADA deficient SCID was made. The patient was stabilized medically. He was given PEG-ADA, and he was referred to a hospital in the United States for definitive treatment. On the day before marrow harvest, unfortunately, his mother noticed a subcutaneous mass in his left posterior leg and asked what that was and if it was important.
And since you're presenting it, I think it must be important. So I wanted to stop here because I know not everyone has access to this DAXP that Rob is referring to. We have relatively easy access here in the United States, and it's performed free of charge. But I'm just curious whether everyone has access to that and if everyone's familiar with what it's measuring and how you use it when you're tracking a patient with ADA SCID. Can you just pop in some comments in the chat box just so we have a sense of where people are at with the DAXP? I think the votes are to get a little explanation of what that is and why it's relevant and why would you be using it in ADA SCID. Can you go ahead with that, Rob?
Sure. So adenosine deaminase catalyzes the conversion of adenosine to inosine, which then is converted to hypoxanthine and is excreted in the urine. DXPs are measured in the red blood cells, and the X stands for either AMP, ADP, or ATP, so it's adenosine triphosphate, monophosphate, diphosphate, and it's Dr. Hirschfield who measures them. He measures the adenosine forms as well as the deoxyadenosine forms. In ADA SCID, uniquely, the deoxyadenosine metabolites expressed as a percentage are increased over normal. In people who do not have ADA SCID, the percent is 0. And whereas in children with ADA SCID, it's something greater than 0. The other thing to do is to measure just the concentration of deoxyadenosine metabolites, but this is how we did it in my former clinic.
And like you, we actually use it to sort of monitor how we're doing with replacement until transplant. Is that how you're using it?
Right. Well, we use it to monitor for both before and after. Interestingly, so before, with PEG-ADA, you can get the DXPs down to 0, and your goal is really to get it to like less than 0.2 or 0.3%. As we know, that doesn't completely restore immunity, and immunity wanes over time. Post-transplant, the DXPs do not go to 0. The goal is to get them something under 10%, and that's what we generally see when patients are clinically healthy after transplant. So it is good for diagnosis. It's good for following whether people are taking their PEG-ADA or not. Every time you get it, you also get a free PEG-ADA level. But it correlates, but not exactly, with immune status. So that says there's something else in the immune status going on besides the adenosine problem.
Thank you. That was a really cogent explanation. At this point, but I do want to let Rob get to his punchline, which is really fascinating. But before that, I thought I would just stop and ask if people are familiar. So ADA SCID it's not a typical form of SCID in that it's got non-immunologic features. It's a metabolic disorder. So why don't people just pop in to the chat box what some of the non-immunologic features are that can actually sometimes be a clue to diagnosis, but are also sometimes things that you see later on. So let's just try and get a little conversation going in the chat box about non-immunologic features of ADA SCID, and then it looks like Morna is online, so I'm actually going to turn it over to her once people get putting their comments in. Morna, are you on the line?
Can you hear me?
Oh, yes, perfect.
Yeah.
Okay, so let's let people start putting in some thoughts, and then I'm going to turn it over to you.
Oh, perfect. Yeah. Sounds like some people are putting up some suggestions as to some of the findings that you would see in ADA SCID. So just taking this case maybe from kind of square one, you have, a little boy, let's say you found this child that had lymphopenia. What would suggest ADA SCID in terms of the lymphocyte subset analysis? Anybody in the audience, or maybe anybody can just add that on the chat line. What types of lymphocyte subsets would be affected in ADA SCID? Great. So Nikita mentioned the T minus, B minus, and K minus. And so let's say you perhaps didn't have the lymphocyte subset analysis yet, but you had the radiology department, and you were going to potentially get an X-ray of this child because he had some breathing difficulties. What might you find on X-ray? Okay, so I see Roni mentioned ribs. That's exactly right. There's this very interesting kind of cupping that can happen in the anterior aspects of the ribs. So all of those things are seen in ADA SCID. The other thing, what's the other sort of respiratory manifestation that you might see? Aside from infection. So the thing that you might see exactly is pulmonary alveolar proteinosis. It's a very specific phenomenon that we see in the ADA patients. And once the patients are started on the PEG ADA, all of that actually improves. The rib abnormalities also actually improve with ADA replacement therapy. So very, very good. Anybody else want to add anything to the findings specific for ADA SCID?
Morna, I saw Teresa mentioned mastocytosis, which I haven't heard as an association before. Have either you or Rob heard of mastocytosis?
I did have one. I'm sorry. Go ahead.
Go ahead. No, go ahead. I haven't. So
no, I did have one patient with mastocytosis, and we actually thought he had the same thing as this patient did, and that's why we biopsied it, but it was a mastocytoma. So this is now only the second patient with ADA SCID I've heard who has that disorder, but, that's interesting.
Yeah. Well, Rob, why don't you go ahead?
Okay. So this is the patient's butt, and this was the lesion. Kate, did you want to talk about the differential now, or should I just go ahead and present what I have?
I don't know. Morna, what do you want to do?
I think maybe a differential might be interesting.
Yeah. Okay.
So small buttock nodule. It looks pretty flesh-colored. Doesn't look red or inflamed. Is it tender, Rob, when you push on it?
No, it's not tender.
Is
the
it
other
in the
thing
area
to know.
of the ADA? Go ahead.
I'm sorry?
Is it in the area where the PEG ADA is injected?
No, we injected him actually into the thigh, but that would be a good thought to be a sterile abscess or even a not sterile abscess. One of the things about the patient is the patient was clinically well. So that actually broadens the differential a little.
All right, so the chat box is open. Go ahead and put your thoughts in. I know a couple of people have already sort of focused on the nodule, but let's give everyone a chance to weigh in.
That's a really good one, the BCG reactivation.
Yeah, and we always thought of that.
Mm-hmm.
And it could still be an infection. That's what we think.
And we've got a funky tumor. we've sort of covered rheumatologic stuff, infectious stuff, and now oncologic
and
stuff.
Cancer, yeah. The commonest cancer that people with ADA SCID get is lymphoma.
All right, it looks like we've got what we're going to get. Rob, please go ahead.
Okay. All right, so that's my differential. Fungal, bacterial, mycobacterial. We, of course, thought of BCG infection. I'm an oncologist, so I thought of the tumors first, and as I say, lymphoma is the commonest tumor in ADA SCID, although I'm not aware that those would be extra lymphatic, but that would be another thing, an extra nodal lymphoma or even a myeloid sarcoma. Lipoma would be the commonest thing, but a little unusual in a patient that age, and then granuloma from his PEG-ADA infections were the other things that we thought of. So that didn't come out right. I'm sorry. All right. Sorry, this does come out right on PowerPoint, which is how I thought I was doing this. But we'll just go through what happened, and I'll tell you what these other things show. So the ultrasound, we did an ultrasound that revealed a solid mass. It was about 3 centimeters in diameter. I'm an oncologist, so we did a chest, abdomen, pelvis CT, and that was negative. We resected the lesion, and the pathology was, as one of you guys suggested, dermatofibrosarcoma protuberans. What's shown there behind the words is in the upper left is the H&E on the pathology, and you can see it's classically described as a storiform pathology or pinwheel pathology, which this one is. Oh, I should also say these, because I took all this data from published literature, so these are representative cases. They're not all the case from this one patient. The immunohistochemistry is CD34. So a tumor is CD34 positive and factor 13A negative, which is what helps distinguish it from some other spindle-shaped skin tumors. The other thing to notice is if you see on the immunohistochemistry that the tumors go way into the subcutaneous fat. So that's another tip-off. And then this thing in the bottom here was an electropherogram, which showed the characteristic translocation. So these tumors have a translocation between COL1A1, which is collagen, and PTGF-beta, which is the platelet-derived growth factor receptor. This leads to constitutive activation of PTGF, and so not surprisingly, you get a fibrotic tumor from that. We also have, which unfortunately didn't come here, we have classic cytogenetics showed the rearrangement. It's a T821, and fish can also show the rearrangement. So all of those things were present in this patient. It was a very classic case. And so that was the diagnosis, DFSP.
Is there specific staining that has to be done for if on the pathology to pick up this diagnosis?
Yeah, you have to do the immunohistochemistry for CD34 and for factor 13A, and typically you'll also get staining for vimentin and other things you would see in fibrous tumors. Given what we know about mastocytosis now, I would want to stain with c-Kit for mast cells, although I didn't think of it at the time. And then
viral staining.
I'm sorry.
Any staining for viral processes? Any suggestion that's playing a role here?
Yeah, we tried looking that up and tried figuring that out. We were unable to identify viral cause in this tumor, and a viral cause has not been identified in the sporadic cases of the tumor either. So what we looked for, he didn't have.
And Rob, you want to talk a little bit about what the speculation is of why this tumor, particularly because it's a translocation driven, why would ADA somehow contribute to the higher prevalence of this tumor?
Yeah, so...
I mean, any speculation on it?
Yeah, no, we have a theory. The ADA deficiency is also a chromosome breakage disorder, a DNA repair defect. So these children are more predisposed to have rearrangements and breaks in uneven repair in their DNA. The other thing that they have, besides being ADA deficient, they have a high level of adenosine in their tissues because they're ADA deficient. And so the adenosine builds up. Adenosine is known to be fibrogenic. And so our hypothesis was these children are out in the sun, they're getting ultraviolet light, they're having skin breakage, having DNA breakage, but most people get that and don't get DFSPs. And we're saying the two things that promote it are that the adenosine itself is fibrogenic, so that promotes a fibrous tumor, and then they have impaired tumor surveillance because they're profoundly immune deficient. I do have to say all of this is speculation, but ADA patients are known to have diffuse fibrosis in the liver, the lungs, the adrenal glands, and so they do have a fibrosing pathophysiology. But that's as far as we got with it.
Fascinating.
Okay.
Morna, do you have any last comments?
So I guess, do you think that patients that have this particular, if they have an abnormality that's demonstrated as this particular pathology, would they need a CT scan? We always...
Yeah, not necessarily. So, I have to say, again, I went into working on this patient with less knowledge about DFSP than I have now. And the most common place for DFSP to metastasize, like other sarcomas, is to the lungs. It's important to know that there's no lung metastases because that would radically alter the prognosis and the treatment. Doing an abdominopelvic CT in DFSP in general might not be indicated, but actually we did, in looking at other patients, pick up tumors using abdominopelvic CT. And so so it's a little bit of a different animal in patients with ADA SCID than in patients who do not have ADA SCID. But, I would do the chest CT and the abdominopelvic CT. You can make an argument not to do.
Sounds like you have a few other slides in your presentation, but I think that the gist of the couple of slides is really going to be that this patient underwent gene therapy.
Right.
ADA gene therapy. So just if you could make a comment on just briefly on transplant outcomes for ADA SCID and why this child went to gene therapy versus getting hematopoietic cell transplant.
Okay, so he didn't have an HLA identical sibling, which, if the patient did have an HLA identical sibling, that would still be the treatment of choice. And children with ADA SCID who get transplanted from an HLA identical sibling do very well, as do other children with SCID, particularly when they're caught early, and that is from Sung Young Pai and colleagues, although as we know this patient wasn't caught early. Often people who have ADA SCID, if they don't have a matched sibling donor, they get a haploidentical transplant. And that has not gone very well for people with ADA SCID. The mortality is about 50%. And those that don't die from that, a lot of times they actually reject the haploidentical marrow. And so when we did this protocol, we said people should, we said if you have an initially identical sibling, go to transplant. If not, we said that the outcomes of unrelated donor transplant were poor enough that we would do gene therapy, which is what we ended up doing with this child. That's all we did at our hospital, actually.
Yeah, I think that's pretty much what most people are following these days. Great if a matched SIB. If you've got a haplo, definitely go to gene therapy.
Right. And other people have said that. Bobby Gaspar wrote a paper about that, too, or had a paper where he had that opinion. He's also a gene therapy guy, though.
Mm-hmm. We need to move on to our second case, but a couple of people have put in some very interesting comments in the chat section about Gleevec, which certainly is used for a couple of other fibrotic tumors. Is there experience using Gleevec specifically for this tumor?
There is experience using Gleevec for this tumor. However, not in this setting. So Gleevec has been used in refractory cases when people already do have lung metastases. There is some other chemotherapy that can be used, but it's not very effective, whereas Gleevec is quite effective. Gleevec has also been used in the adjuvant setting after resection of a tumor, but the duration of therapy in that is unclear, and that's not really it's been used but not well described. Gleevec has recently gotten approval for neoadjuvant therapy for DFSP. So for a defined course of treatment prior to resection. The reason we do neoadjuvant chemotherapy in general is because we want to shrink tumors, and before we resect them, the most classic case of that is breast cancer, where you want to have you want to do a lumpectomy instead of a mastectomy. These tumors also important to shrink because, as the pathology showed, they're very infiltrative. They send out tendrils deep into the subcutaneous tissue, and so it's hard to get a margin on them. The standard recommendations, if you're either to do Mohs micrographic surgery or to do a resection with a margin. The smallest margin I've seen as a standard recommendation was 2, and the largest I've seen was 5.
Centimeters?
The other thing I should mention, this child, and actually most of our cases, had multiple DFSP lesions, and so resecting with 5-centimeter margins would be difficult, and Gleevec recently has gotten an FDA approval for neoadjuvant treatment for this disease.
Fascinating. Thank you so much. I do want to give nice time to the second case, so I think we will move on. But thank you very much, Rob, and thank you very much, Morna, as well, for some really insightful comments. Our second case, while it's coming up, let me just introduce the two speakers, Thalita Diaz and Rhaianny Souza. They're from Brazil, Belo Horizonte, which is a beautiful part of the country if you get a chance to go there. And if you thought this first case was wild and woolly, the second case is really wild and woolly. So I know you'll find it interesting. As I saw it for the first time today, I thought, what a fascinating case to present. I think it's really good for everyone to see this case. So let's pull up their presentation, and we'll get them on the line and get started. Oh, here we go. All right. Rhaianny and Thalita, are you on the line?
Yes.
All right. Welcome to the webinar. Please go ahead and get started.
Good night. This is clinical case about the patient DMR He is 3 months old male, born in Sete Lagoas, Minas Gerais, State, Brazil. His pregnancy was without any complications. He was born in term, received the BCG and the hepatitis B vaccination on his first week of life. Clinical presentation: dry skin, diffuse erythema, eczema without infections. He has prominent forehead. Next. Family history pedigree. No consanguineous parent. The first son died at 8 months due to a non-confirmed pneumonia diagnosis. The second was found dead on the crib at 5 months. Both had eczema in common. Laboratory data: hypogammaglobulinemia and normal lymphocytes subsets. In CBC, severe neutropenia and bone marrow finds. He viewed granulocytic lineage hypercellular with discrete changes in maturation.
Stop here and just start thinking about the differential? We just take a moment, this is Alexandra, just to think about the differential for this one. Okay, so we see one for WIM. So WIM, I think, would be consistent in terms of, I assume they're thinking because the marrow shows a lot of cells. Neutropenia, so that would be consistent in the hypogam, but I don't know about this kind of skin presentation. Also, it's autosomal dominant. We're trying to think of something potentially as recessive. Scott Aldridge, good thought. There's, if we think the family history is consistent, a boy and girl. Omen, you know, with the skin findings. The flow might be a little atypical of the good numbers in naive, but it's confusing. Dyskeratosis congenita, again with the skin findings. Okay, and how about the AK2 deficiency? So, you know, again, looking at something consistent with SCID and presenting with cytopenias as well. The confusing thing I think here is all the normal number of lymphocytes and a good kind of distribution of the lymphocytes and having the agammaglobulinemia. If we had neutropenia plus no B cells, what would we be thinking of? Neutropenia and no B cells with agam. Yeah, BTK deficiency, exactly, because this is a boy. Or CD40 ligand deficiency with B cells, right? And having the normal number of B cells. How about other reasons if we take away the B cells for congenital neutropenia? Yeah, Omen with the WIM mutation that's there, CXCR4. Okay. So, and then in terms of the neutropenia and showing lots of cells on the bone marrow. Okay, maybe we should go back a slide. Okay, let's keep going forward because this is, you know, there's only so much time left. Okay, I think we had great things on the differential. We have a boy and a girl, so we think it's autosomal recessive maybe and not X-linked, and something, you know, where we see some sort of change in the bone marrow as well as affecting. Rothman is a good suggestion. Okay. Why don't you keep going?
Really, we don't know what this patient has. We reviewed the neutropenias, and the thing we thought more probable is poikilomatose claricosius poikiloma type with neutropenia.
Okay.
Okay. This is the phenotype we found of this disease.
Can you just repeat? I'll just repeat for them because it's a little hard to hear sometimes. Poikiloderma with neutropenia was their leading difference on the what they suspected. So poikiloderma with neutropenia. Okay, go ahead.
Neutropenia associated with poikilodermia claricosio type, it's a kind of disease that occurs with skin atrophy and papillary erythematous rash. The onset occurs in the first year of life. The rash propagates centripetally from the limbs and comprises a papillary rash followed by plaques of hypo and hyperpigmentation and telangiectasias. Neutropenia is often severe. Granulocyte maturation arrests the promyelocyte stage is rarely observed, but this granulopoiesis with late arrest is often seen. We've thought about that.
The clinical dermatological features are not exactly what we saw on the patient, but that was the only thing that we thought it was possible to be considered as a neutropenia and without any other features on the lymphocyte counts. So we are kind of lost here, wishing for your wisdom.
Right. So, if you're reading of this, I saw some evidence of B-cell defects. Did you know much about the other babies that had died, the siblings?
No.
No. Okay. And how about thinking about other, it doesn't seem like the B-cell phenotype has been that predominant in the other patients with poikiloderma and neutropenia, although potential.
Alexandra, it has not been reported, but our one patient here at CHOP does have hypogam, not as significant. This is now an older girl who's 4-ish, and her IgG is in the 300s. So definitely hypogam, but not as pronounced as this baby.
And this baby is very young. Have you had follow-up immunoglobulin levels? Because maybe it's just, maybe they would make.
We arrived just now.
Do you have genetic studies pending?
No, not yet.
Do you want to talk about the genetic differential as well for that, for poikiloderma?
No, we don't think about BTK disease because it's not X-linked. We thought in some recessive because in Minas Gerais we have a lot of small towns with a lot of consanguineo in the small seizures.
Mm-hmm.
We don't know yet.
I think Morna had a good point over in the chat box about vaccine responses. Do you know about your patient's vaccine responses? Oh, here we go.
No.
Well, and the baby's only 3 months old at this point, right?
Yes.
So it might be maternal antibodies.
I see.
And we received the first vaccines like BCG and B hepatitis, and he didn't receive more vaccines.
And the hemophagocytosis, do you think, is that just finding, or do you think there's any evidence? Because the other labs in the clinical presentation seemed healthy for that.
We don't have this gene test.
Okay.
Go ahead, Alex.
No, go ahead.
Were you impressed with the hemophagocytosis? Did you think that was a really important facet or an important part of this disease, or you just saw a hemophagocyte here and there?
Yeah, but it was not a massive hemophagocytes. It was just a. So we are not putting a lot of emphasis on that. It seems to be a casual finding.
He doesn't present any other symptom of hemophagocytosis. He does not present fever. He doesn't present hepatosplenomegaly and other findings.
Yeah. Kate, because you have another patient with this. I've never actually seen this before. I did look it up earlier more, but for your patient, how did the skin kind of evolve over? Because the typical skin presentation right now isn't as consistent, but it's hard to know what that looks like in a 3-month-old.
Right. So I met this little girl after the diagnosis was made by dermatology, but they did take some very nice pictures along the way. And as a baby, she had a very inflammatory picture, almost like incontinentia pigmenti, but not the streakiness, sort of whole body. And then as she got a little bit older, closer to 1 year of age, which is when I first met her, she really had the classic poikiloderma, that really pronounced sort of hyperpigmentation with hypopigmentation, really very speckled looking. And that's continued to evolve and even get a little bit more pronounced as she's gotten older.
And I think some of these children have been treated with GCSF. Was your patient treated with GCSF? Or is the neutropenia not that severe?
No. We have not decided to treat yet, but so this is a very recent case that, as you noticed, is a young boy. So we are just following. He's fine, clinically fine. So we decided just to follow clinically and see how it goes, where it goes, his neutropenia. But we have not started with CGSF.
And it does seem that, just from my reading of this, that sometimes in the neutrophils actually respond. And if you have a marrow that has the neutrophils there, you might actually see the neutrophil count come up when there is infection. And the siblings may have actually had more of a problem because of their hypogam with the pneumonia.
Mm-hmm.
I think it's really interesting. You had to keep us posted what happens.
Yes, we sure do.
Thank you.
We are just in our last couple of minutes. I think it might be worth just stepping back for a moment and asking everyone to just think about neutropenia as a general category. Sometimes we don't in immunology see the neutropenia patients. They go to hematology instead. So I think this case is incredibly instructive because they're considering a diagnosis that's even a super zebra among zebras. But let's just step back for a moment and think about non-hematologic things that we see sometimes associated with neutropenia. So just as an example, deafness and HAX1. So you want to just pop in your ideas about clues to the cause of neutropenia that are more somatic in nature. There are just a few. The congenital neutropenias don't have a lot of other features as a big generalization. But let's see how far we get just by thinking about somatic tissues in neutropenia. So in this poikiloderma neutropenia, it's really the skin. What are some other things that you can come up with? I myself can only think of a few, but Alex, maybe you've got a little more.
Yeah, well, I can
wrapped around.
Let's see, with the albinism. So that's a great one to bring up. Albinism, neutrophil defects. I was looking at this case while in clinic today with a PGM3 deficient patients, and the family, one of the kind of pediatric family that I followed with PGM3 deficiency presented early in life, in infancy with neutropenia and rashes. So that kind of crossed my mind with this as well, with this case, PGM3 deficiency. If you have a patient with eczema, recurrent infections, and more T-cell lymphopenia. Wiscott, someone just put down 2. Yeah, G6PC3, again, glycosylation. The other one that, we see not so much in early childhood, but has been described as pediatric neutropenia is GATA2 deficiency.
Right. I just heard Steve Holland say that among congenital neutropenias, 20% are due to GATA2, which really knocked my socks off.
Yeah, there's been a big series. I think the more people look, the more that people find it. But there's been pediatric neutropenia, whereas a lot of the patients that were initially described and initially that we were seeing are more kind of adolescent and adult onset, but there's been pediatric onset with neutropenia. People are bringing up really great ones. And I like the, some of the ones that were initially brought up in the differential as well, like AKT, AK2 deficiency, and the, I think, ones like CD40 ligand deficient, some of the more common things too that can initially present with neutropenia.
Now I see PNP deficiency listed there by Lahari. I guess I wasn't aware that neutropenia was associated with PNP. Can anyone help me sort that out? Is it a common thing, or maybe just if you get autoimmune neutropenia, you get it? Okay, well now I don't feel quite so I don't feel quite so dumb that I'm not the only one. So
yeah, but
I don't know.
ADA deficiency also has neutropenia, so that's interesting. The PNP deficiency has it.
Yeah, thank you, Lahari, for posting that. Oh, there you are.
Oh yeah.
Okay.
SPDS is the Schwachman-Diamond syndrome for those of us who don't live in acronyms all the time. I don't know about ligase 4. I don't know if anyone else does. I don't know. I don't think of that.
Ligase 4?
Certainly they've got somatic stuff. I didn't know about neutropenia, but
it's a great list, though.
That is a good list. Thank you, everyone, for your input. Oh, and of course, gain of function with Scott. But now, let me just, since I have never in my entire life seen gain of function with Scott mutations, they don't get the other with Scott stuff. They get the neutropenia, but they don't get thrombocytopenia. So I'm not sure they do have somatic things. I think it's a relatively pure neutropenia, is it not?
Yeah, that's true. That's true.
Not to be picky, whoever posted that, but just to be clear. All right. I think that we are at the end of our time, and I thank everyone for being so engaged and creative. It was really terrific. I also think we had 2 amazing cases tonight, so I really want to thank the presenters for really bringing their A games. These were really amazing cases that I think just were wonderful for everyone to hear. I want to thank our guest mentors, Alexandra Freeman and Morna Dorsey. I want to thank the CIS staff. And from Joyce Yu and myself, we say thank you very much. And we will have another one towards the end of October, so keep an eye out for the notices. Take care, everyone. Good night.